Good evening, a warm welcome to everyone. Thank you for joining the community of practice tonight and sharing with us your evening time. We really appreciate that. I know we've got more people trickling in. We do have a very full program for you tonight. So I might kickstart with the introductions while other people join us tonight. Just sharing my screen. Perfect. Would you mind giving me a thumbs up just to say if you could see my screen? Yeah, great. Thank you. Amazing. Thank you. All right, let's kickstart it where there's more people joining us tonight. First, I'd like to start with an acknowledgement of country. In the spirit of reconciliation, we acknowledge the traditional custodians of the land on which we meet. And for me, is the Wurundjeri people of the Kulin Nation. We pay our respects to the elders past and present and extend that respect to all Aboriginal and Torres Strait Islander today, for they are the safekeepers of memories, traditions, and culture. We recognize their connection to country, land, sea, and community, and the role in caring for and maintaining country over thousands of years. May their strength and wisdom be with us today. Just a bit of housekeeping. Thank you for staying mute when you're not speaking. You're welcome to unmute yourself to ask questions. We love that. Or you can put the questions in the chat box, which Kirsty is going to help me monitor that. This session is being recorded. And if you wouldn't mind joining the session using your name, and that helps us with providing the CPD points and certificates, please. So some instructions here on how to change your name if you need to, but I can see most people do have their names on when you were signing in. All right. So a brief rundown of today, we're starting with some welcome and introductions. What I might start with is focusing on some of the data that show us what the gaps and opportunities in asthma care may be. And then I got lots of a big audience of people joining me today to share their perspective from the hospital to consumers and families, patients themselves, and from the GP side of what the challenges may be with following asthma guidelines. And then we'll hand over to Joanne Flewen from the community asthma practice to tie it together on how the service may be able to help us with navigating some of these challenges. All right, and hopefully by the end of this session, you'll be able to help guide you implement best practice management in your practice and be able to describe some of the resources and local services available for children living with asthma and identify some opportunities for collaboration and support for you. There will be no data today locally, so we'll skip that part. So first of all, there's quite a lot of us, and so that we know who is in with us, would you mind just typing into the chat your name, the organization you're from, and your role, particularly in asthma, please, so that we can have an idea of who's joining us in the community of practice tonight. Fantastic. So as usual, we have a very big multidisciplinary audience here. We have from the Department of Health, we have hospital-based doctors, we have community-based clinicians, Stephen Care Victoria, and Kevin, again, from Asthma Australia, welcome. Good to see lots of returning faces and names, and more clinicians from the community asthma practice. Love our GP colleagues are here, and Sunshine Western Health nurses. I think more will be trickling in, so keep an eye on who's there. So I will continue on. All right, so for many of you that are returning, and they may know me and Kirsty, we've been co-facilitators along with Shiv Shanti Kumar. For those that don't know me, I am a general pediatrician. I'm based at the Children's Hospital, and I'm also a clinician research fellow from the Murdoch's Children's Research Institute. My co-facilitator is Dr. Kirsty Thomas, who's a general practitioner and from Forsyth Park Medical Centre, which is in Truganina, and I think it's one of the asthma capitals of Melbourne, I believe. And she will be sharing with us some of the experiences in GP land with challenges of following asthma guidelines. So what I'm going to start with is just putting into numbers what may be some of the opportunities and gaps. So just want to describe this data first. Back before the pandemic, we follow a group of children. There were about 760, and we recruited them from 3 hospitals. So the Children's Hospital, Northern Hospital, and Geelong, so the Northwest Corridor. And we got their consent to follow them for 1 year, including contacting their GP, having surveys with the family, and asking for permission to link with PBS, which is Pharmaceutical Benefit Scheme, so we know what medications they use, and also Medicare Benefit Scheme, so we know what services they use. And we really want to see what happens when children leave the hospital, and so that we can truly understand where the gaps may be and if they do come back to hospital. As you can see in the blue boxes, it won't be a surprise for all of you. Those are what we think key areas in asthma care of children. And they are evidence-based, important things that we feel are important in the care of children. The yellow boxes below are in this cohort of children we follow, what percentage of children had those important things done when they were in the hospital. As you could see, only about half of children had it documented that we review whether they have other areas of atopy like food allergies or eczema or allergic rhinitis. And we know that if we manage those things, we can also improve asthma. Quite a big number, and almost 90% left us with an asthma action plan, which is a good thing. Only 65% had a documentation that would review their inhaler technique, which I think is a really important step when children are in hospital. And about 75% had a review of the asthma education. The part that we felt that we could probably have improved on, because remember, these are children that are severe enough to be admitted to hospital. So that only about 10% will prescribe a preventer medication while they're in that hospital admission. And only 16% were asked to continue on their preventer when they already have one. A very small number were given the medications before they leave. So a lot of them just left with a script and not the actual medications. And only a small percentage, 17%, will follow up in hospital. And this was probably the most severe one. The vast majority were asked to follow up with their GP. So often the responsibility has been put in the family to seek that follow-up themselves. So what happened after they left us? We know by the link Pharmaceutical Benefit Scheme or PBS data that only about 50% of the families actually fill that script that the hospital gave them. So remember, only a very small number were recommended to start on a preventer. And out of that very small number, only half of them fill the script after leaving us. For those small number that we asked them to continue on the preventer, only about less than half of them has an active script when they left the hospital. We then surveyed their nominated, who they think was their nominated usual GP, and only 40% of the GP that we surveyed actually said that they knew of that hospital admission. So the discharge summary did not get to the right GP. And when we link the Medicare Benefit Scheme data, only 36% were able to see their GP within the 7 days after going home. And out of the cohort of 767, about a third of them were readmitted again to a hospital in Victoria, again for the admission for management of their asthma. So that's a relatively big percentage of 1 in 3 patients in that 1 year after one hospital admission needing to be cared for by another hospital for asthma. So as you could see, there's lots of opportunities and gaps along the way. So we're going to drill into it because I presented numbers. Now we're going to listen to the stories and understand a little bit behind that, just to tease it out and unpack what may be the reason and challenges. And I think many of you sitting there probably are thinking, oh, I think I know why. So I invite you to contribute your experiences as we share ours. So the next speakers would be first to start with is Esther Yap, who's our currently a pediatric fellow working at the Children's Hospital. And she completed her advanced training program and a project in asthma. Esther was previously a pharmacist and worked across multiple services around Victoria, and is working on a project with me on how we improve asthma management. Following shortly with her, we will have Laura Santoro, which is our very brave Year 12 student who's been helping us understand asthma from the young person's point of view. Laura was diagnosed with asthma at the age of 2 and has participated in lots of workshops and activities in helping us better tailor our asthma care to young people. And following her will be Anna Marie Restol, is a parent of an 8-year-old girl who suffers from asthma and also care for her own parents. Anna Marie is a librarian in the Brimbank area and has lots of background in teaching, aviation, and business. Anna Marie has been part of our ICAM group for quite a while and present a very strong consumer voice in helping us understand the challenges from the family's point of view. So Esther, I'll hand over to you first.
Lovely. Thank you, Catherine. It's a pleasure to be talking to you guys today on a Wednesday evening. And I'm so glad that I'm in great presence with Laura and Anna Marie today, just talking about how we can better manage asthma. So I was asked to kind of present from a hospital point of view about what the challenges are. And this is mainly speaking kind of, in a short stay unit where the majority of asthma would kind of present and be managed from the ED setting. And I've kind of thought about 3 different groups of factors just to kind of delineate it in our mind, and thinking about what the barriers are in hospital. In a busy hospital, we often have frequent change of staff and with variable experiences with asthma management. And this also differs between hospitals. So somewhere like the Royal Children's, we would see a lot of asthma managed in a short stay unit. But if you go peripherally, like where I've worked in Eastern, they are very good at managing asthma, but you might have differences as well in the way we stretch things or the way things are managed. There's obviously a high patient load, with asthma being one of the very common things that we would see. And the acuity means that we're very good at doing the burst therapy. We're very good at stretching, but sometimes the longer term preventative treatment does get overlooked. And we assume that a lot of things are already done. Like someone's talked about preventive therapy, someone's sorted out the education, someone's looked at the triggers, because our focus is very much on let's manage the patients. They look a lot better. So they're not hypoxic. They've stretched, great. Let's do what we call a criteria-led discharge, which is when they've gone tick, 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 I've stretched to 3 hours, I've got my scripts with me, I've received some sort of education, and I get home. And now I think we are getting better at doing that, but where things fall through the cracks is when it gets too busy, and we've got to make sure that everyone's being looked after. So sometimes the quote unquote less important things gets overlooked. And we love a good guideline in hospital. We love templates. We love kind of being told what to do as junior staff, essentially, so that we can keep the patients safe. But sometimes I think there can be a lack of personalization, because we're so focused on making sure that they fit into a mold. And when patients don't fit into a certain mold, we go, what do I do now? So I think that can be sometimes a barrier in terms of how we operate as clinicians, in that we tend to put things in boxes. And then another issue that I kind of thought of in terms of a hospital factor is the variations in asthma action plan. Sometimes in RCH itself, and also in different hospitals, what kind of asthma action plans they have, which I can show you a picture of. Oh, we could probably do that now. So as an example, the National Asthma Council, which a lot of GPs would use, that's the one on your very left. It's got
so sorry to interrupt her. So your mic seems to have just gone off. Am I the only person who's hearing that?
Asthma action plan. it links
I'm having the
the
same problem,
schools. Would you
Esther.
use it
Esther, can you
as
hear
well?
us?
To kind of
Esther,
can you hear me now?
Yeah, I think you were breaking up a little bit. Can you try again?
Okay, yeah.
Oh, no, but
Is
much
it
better
fixed
now.
now?
Your
Yeah,
screen's
sure.
frozen, but you're sounding much
Okay.
better now.
Yeah, we've got you back.
Yeah,
Okay.
fantastic.
Maybe I'll turn off my video. Is that better?
No,
Yeah,
you're
sorry, you have to
good
talk
now.
to a black face, but hopefully that might improve the sound quality. Apologies for that. So where I was saying was comparing the asthma action plans kind of between hospitals, pediatric hospitals. And in the Royal Children's, we've kind of adapted our asthma action plan that we have through our program through something called EPIC, so that it kind of mimics the National Asthma Council and Asthma Action Plan to allow some consistency between asthma action plans, but this is only available through the RCH kind of program. So I appreciate that maybe externally people might be getting different asthma action plans, and that I think compounds the confusion that a lot of patients might have, because they're getting different information from different clinicians each time to present. And sometimes they don't always present to the Royal Children's, they might present to other hospitals. So I'll speak to it later, but I think there is a role to perhaps create a centralized asthma action plan, so there's consistency that the patients will receive. So if I just go back to the first slide, Catherine, is my sound quality better? Good, great. So just going back to the first slide, perfect. So that's kind of what I brainstorm in terms of hospital factors. In terms of patient factors, I think sometimes it's really variable what access to follow-up care you have, and what Catherine was alluding to before. Sometimes we say discharge to GP care or discharge to community asthma program, which is only accessible to some families, discharged to the asthma clinic. And it depends a little bit on how severe your asthma is, but there is a big kind of variability in asthma care. And there's a lot of assumed follow-up, when sometimes the reality is that we don't actually know if patients are followed up in a timely manner. And variably, who sees who. With patients that are from a culturally diverse background, there's a language barrier where it's more difficult to explain things and ensure that they're having the optimal kind of asthma care as well. There's also kind of a gap in kind of health literacy that may present as a challenge. And I think sometimes there is a perception of power imbalance where a lot of families don't feel empowered to ask questions because they see that it's, a waste of time or too silly. And I hope that isn't the case when we look after patients, but I'm aware that it is out there. So it'd be interesting to hear what Laura and Anne-Marie talk about later. But yeah, I think that can be a factor. In terms of clinician factors, this is similar to what hospital is, but there's very different practices between clinicians, and I think particularly surrounding the area of commencing preventers. Now, we've tried to come out with guidelines, I think, in the hospital, but there's still a big variability in when people will talk about preventers, and also variation in how it's explained, so that families understand why a preventer is being commenced. And there's, I think, a big fear of side effects as well, in terms of what long-term steroids will do to you. And depending on how you explain it, sometimes it can be a scary concept to a lot of families. And more often than not, asthma is managed in the hospital in a short stay unit by a lot of the junior staff, because it's seen as a kind of the bread and butter of pediatrics, and things that we expect a lot of junior staff to upskill in very quickly. And then lastly, I just talk about kind of the clinician factor of a timely completion of a discharge summary and liaising with our lovely GP colleagues, which sometimes in a busy unit does kind of get pushed later and later. So in terms of following on from this slide, if I go to the next slide, I've just tried to brainstorm some ideas of solutions, and we can talk about this later, I'm sure. But something that we've tried to implement in our Dolphin unit, short stay units, is mandatory kind of asthma education for staff, including this kind of community of practice. Not quite mandatory yet, but I think something that maybe we might be working towards. And I think previously, Catherine, which you can comment on, there was an asthma champion role as well. And in our set kind of criteria-led discharge, and by what I mean by criteria-led discharge is that sometimes to aid timely discharge of families so they aren't waiting around for ages, is we have a checklist that people go through to make sure that things are done before they go. And this could include asthma action plan, education, assessment of inhaler technique. And I think in there we should also include discussion of preventative care and maybe a supply of a script if we can. As well as, like I've mentioned before, centralized, personalized asthma action plan with wide clinician access, not just RCH and elsewhere as well. So in terms of what solutions we can for patients, I think a translated asthma action, we do have some in some languages, but not all. And there are some asthma apps available out there, but not many. I think the KISS asthma one is being updated as well. At RCH, in terms of clinician support tools, because we have a program, we've tried to brainstorm about how we can help junior staff that are time poor to really upskill them in terms of managing asthma and getting a timely discharge summary. So we tried looking up kind of templates that we can use, as well as the development of new RCH guidelines. We go to the next page, which was released last year in June. So you can see on the right side there, there's preschool asthma, but there's also one in adolescents and asthma, and also asthma in school-aged children. And a lot of it is surrounding how to start preventers, how to assess the child in terms of how they're going with their asthma. So I think that's been rolled out, and I'm not too sure how well it's been received. So it'll be good to hear what Kirsty's opinion on that is. We've also got on the left there some translations that are available at the moment for the National Asthma Council Asthma Action Plans. So that's all I have. I don't know if anyone has any questions.
Fantastic. Thank you so much, Esther. I've got a couple of questions from the chat. If anybody else has questions for Esther, anything they want to glean, then please pop it up in the chat. One of the questions comes from one of my GP colleagues. Stephen was wondering if you have any breakdown in terms of what patients are falling through the gaps. Do you see any common reasons why patients are falling through the gap? Do you see it as patients with language barrier? Is it a socioeconomic thing? Is there commonalities amongst patients that we could maybe target? Because we often use that term, don't we, falling through the gap. But what does that actually mean?
Yeah, absolutely. And I think a lot, one of the first indications is the readmissions. Often they come back being readmitted, 5th, 6th time, or within the 6 months, they've come back 2 or 3 times. And I think sometimes we fail to emphasize, one, the preventative care, or fail to look at what else is contributing to their representations. And yes, I definitely think a lower socioeconomic status, health literacy definitely compounds it. And you find that sometimes it does take a bit to identify what exactly is causing the trigger for it. And what we can do to make it better, and what the compliance is with preventer therapy. For example, last year when I looked after a family, there was a lot going on in the family. So low socioeconomic status, and there were twins, both with asthma, and they had 3 or 4 presentations within 3 months. And when we talked again about preventer therapy, there was a lack of understanding in terms of what the role is. There was a lot of fear about the side effects. And there was a lot of frustration with the family about why this keeps coming back. So I think in terms of what patients are falling through the gaps and what we can target, I do think it is that lower socioeconomic status group. And actually I find the preschool age, I don't know, Catherine, if you've, that difficult group to manage, where they're getting recurrent viral infections through daycare, they maybe don't quite fit the bill for, there's just that kind of preventer therapy uncertainty, I think, as well. And the uncertainty whether you've got asthma, you don't have asthma, you've got viral-induced wheeze, there's that lack of label, and that I think compounds it. So I think those 2 groups are a big one that are falling through the gaps.
Thank you, Esther. There's a couple of other points here. I'm not sure who RL is. Thank you for your point. We don't often get rural GPs in, and it's probably not been so much of a focus for us, being a large urban centre, one of the best paediatric hospitals in the world. People who fall through the gaps, people in rural healthcare. I don't know, feel free
Absolutely.
to come off mute if you feel that you want to discuss this, as you'll be the expert being a rural GP. But people with less access to GP appointments and less access to a variety of GPs who might have a specialist interest, such as myself, less nurse practitioners and nurse-led clinics, and the demographic in rural areas. I've certainly worked in rural areas back home in Scotland, and people tend to present later. They deal with more illness, in my experience, and much less reactive towards illness, cope with a lot more. But feel free to wade in on that. Translated well with my Scottish accent. Yeah, I failed the English test for my permanent residency, but I think I do okay. And then Stephen put in another point as well. This is very much my demographic. Parents who both work. Parents who are working 6 days a week, sometimes 7 days a week. A lot of my patients, one parent is truck driver, so it's not just 6 days a week, it's 6 days a week, not in the state. And only a grandparent or an older sibling. I often get a cousin or an older sibling bringing patients to hospital. So I think these patients are, like I said, the ones that fall through the gaps. I'll maybe speak to that from the GP point of view, because I think being consistent in general practice and having a GP that you can go to is a way to patch that up, just through the nature of the system. If you're falling through the gap already and you're being provided with an appointment, or you're attending ED, it's not always getting that continuity of care. And I think maybe this is something Jo could speak to as well, our wonderful nurse practitioner who works with community asthma team, because this is exactly the sort of families that community asthma programme work with.
Definitely. Kirsty, are you happy for me to speak a little bit about it
Oh,
now?
please do. Please,
wait?
yeah.
I would agree. There are some, I think there are also some highly educated families that fit into that steroid phobia group that are challenging as well. And we have seen quite a few of those come through the clinic, which we'll get to later. And the other kind of side note for to park with the NP clinic is some of the workarounds that we're looking at is initially engagement via telehealth for those that we really can't physically get in, but we seem to manage to then get them in physically after we've built the rapport and the connection. So it's a little bit of a reverse of what we've probably been trying to achieve previously, but that's something to think about when we're thinking about ways of tackling this. But certainly predominantly lower socioeconomic groups are what ends up in CAP. And then certainly preschool, I would definitely support that. There's a lot of preschoolers that we see through our program, and a lot of that is confusion with labelling, which we've talked about many times before. But I will share a little bit of that later on also.
Anna-Marie has just put trust there, and that's one of my bullet points, as we'll chat about later. I'd love you to talk about that as well and your experience with trust. And something I might touch on as well, which has been put up in the chat, is communication and electronic notes and how we're doing there, because that is something that's quite easily targetable compared to the human factors. I think Danny has just put in here, can you tag child asthma readmission rates to consultants on ward duty? That's a fantastic idea. Is there a flag system that can go up? Does that happen at the RCH?
We do know which one, and we sort of look at that. It wasn't very obvious with associate. And I think, to be honest, in the hospital system, some of the pediatrician on call may be quite familiar. Often asthma, because they do come in quite quickly, they leave less than a day. Often the consultant or pediatrician involvement is actually very little. Most of the time they are cared for by the junior medical staff, often on a rotating basis. And perhaps for that reason, there was no pattern, Danny, when we link them with certain pediatricians or not. In the interest of time, because we got lovely Laura and Anna-Marie trying to share their perspective, should we hand over to Laura to share her perspective as a patient, a young person living with asthma?
Yeah. Okay.
Yeah.
So I'd say that I guess most of this problems or challenges, as you'd put it, with asthma come from within school rather than outside of school. So for example, I guess a lot of kids, I don't think they realize like as for my first point I put, I'm gonna like spray on deodorant or perfume. If I'm going past the lockers, then I'm gonna be coughing a lot, or that's just an example, but I'm not sure. I think that's more on the school though. But I'd say the main thing that I'm kind of confused with is, or that I've had questions and troubles with, is the asthma action plans. Particularly in primary school, you had to renew it every year, which I didn't really need at all because it stayed the same for years at a time. But the school always just requested the same one over again, and then you'd have to pay to book another GP appointment to renew it. And then yeah, we had to provide our own Ventolin, and then they'd hold on to that. And I always had my own Ventolin on me, so if the one that they held on to, it normally went at a date, and it was just a waste of money on my part. And there was a lot. There could have been more, but there was at least some education on what asthma was to when I was in primary school. As soon as I entered high school, I don't think I'd ever heard anyone mention the word asthma. Um, the only time when I first in year 7, they never even requested an asthma action plan, which I thought was weird. I think they have it marked on the roll that I had asthma because it has like a little red cross next to it, which normally means that there's like a health something concern with them, but the teachers don't actually know that I'm asthmatic. I have to tell them. So with sport teachers, I need to tell them, I have asthma, and it goes, oh, do you have your own Ventolin? Do you have your own medication? Do you know how to medicate yourself? And that's usually the questions they ask me, and I'm kind of I assume that they know that type of stuff so they can be aware beforehand, but I guess it isn't a thing. And then I guess yeah, I think I put spaces in here as well. I've never seen another teenager my age use a spacer, like, or even in primary school. I've never seen another kid use a spacer. Especially when they're self-medicating. I guess I've had friends tell me that it's because they're embarrassed to use it because it's really chunky, and I guess it looks a little goofy to outlookers. So I used it, but I think it's only because my mum forced me to use it from a young age. So by the time I entered high school, it's kind of like, oh yeah, I'm used to this. Hey guys, I'd go to my friends and go like, hey, this is kind of cool. I love my space of it. Anyway, uh, and then also, I guess because in my high school in particular, because there is no asthma action plans, and a lot of teachers don't know about it. It means that my friends, I know that they don't ever go to the GP to talk about their asthma. I know that the last time they updated their asthma action plan was in primary school. And I'd say that's basically it, but did I have more on the next slide?
Yep.
Yeah, so my friends, I mean, then they were asking me about it, because I know that there have been friends who I've said, you might have asthma, they've gone to the GP and then they've been diagnosed with asthma. But they just don't know much. So I think that's just because of the lack of education on asthma in high school. And in the last point I put that if you are diagnosed, or if you do go to the GP for like say like a cough or something, and you do get diagnosed, then like you might get education. But if you, or say you're like, I had a friend who was she was concerned about money, and she didn't want her family having to pay for any asthma medication. So she wasn't aware of any, free initiatives or where she could get asthmatic resources from. So I think I'm not sure how to approach that, but it's just if you don't get the healthcare for it, then where can you find the resources is where she was confused with, and I guess I'm also wondering about that. Yeah, and I put here just maybe get some form of initiatives, some form of education for asthma in high school, because I think that's where a lot of kids could get medicated for it, but they just don't, and then that goes into adulthood, and then I reckon they're even less inclined to go to the doctor for it in when they are an adult. And then I think that's it from me.
That was
Thanks, Laura. That
fantastic.
was incredible and really lovely to hear what happens in a high school, isn't it? The difference between that and the junior school and the gaps there. I'm just wondering if anyone has any questions they wanted to ask Laura.
Feel free to put them up in the chat. Hannah's actually, I've noticed down there, so Hannah has popped up in the chat CoHealth's YouTube page. They've got some really good videos. We talked about it a few times, made by young people with asthma. I'm trying to make asthma cool, but they are really good. But I suppose for young people, and Laura, you could maybe speak to this, it's finding those resources. Age group of teenagers is such a time of popular culture. You guys create popular culture. So when you're speaking to old people like us who can't really remember high school, we're not really the best people to direct this. The CoHealth YouTube videos, as far as I'm aware, were actually made in conjunction with teenagers with asthma. So they are really good. Did you have any other thoughts, Laura, about how the healthcare professionals could integrate into school, other than your parent or you booking an appointment? What would work for you guys? How would you want information to be delivered?
Guest speakers, like I know that could work. Because I mean, if you force all the kids to go to like an excursion, especially it's probably be better in the younger year levels when they don't have when they're not in BC year 11 or 12, and just have someone to come in and speak to them.
Yeah.
I reckon people would listen to that, or if even just if it was it I don't know if you guys wouldn't have any power, but if it was just integrated in the health education theory, when in the younger year levels you have like normal PE and then you have one period of health theory. So if it was like integrated in that,
Something that I know a couple of local practices near us do is they have a GP in reach program. So they have a GP and the practice nurse actually go to school and you can book an appointment with them. So it's sort of an autonomous thing you can go. And most of it centers around teenage health, sexual health. And asthma is probably one of those things that you may, tell me not, think are more something you would speak to your GP about with your family. But if there was like sort of a health professional roadshow, if once a year or once every 2 years, you could have a group of health professionals come and do like an hour's talk about common health factors: mental health, sexual health, respiratory health. Would teenagers be open to engage in that? Would they be interested in that, rather having it from your teachers? I can imagine that's always an awkward interface, isn't it, when your teachers are trying to tell you things?
I think that really depends on the person. I think a lot of my friends probably wouldn't be interested in that from what I've heard, but there would definitely be some people that would want that.
I've got some more questions here. One of the GPs is asking, what do your friends or social media, social groups think about smokers and secondhand smoke and vaping, specifically with asthma?
So I know that at our school, I mean, the rate at which teens are like vaping and smoking is insane, especially within my school. They don't even mention asthma. Like if I like the friends that actually I can't think of any asthmatic friends that actually do smoke or vape, but I've never heard anyone on this say. I've never seen. but I think I'd say most kids they see like vaping as like it's kind of become the norm now. What I I personally hate it. I don't see the point, and it stinks. They stink up the school bathrooms and the school buses. They should just get rid of it. But,
We are working on the getting rid of vaping. I think we're about to have a whole generation have acute nicotine withdrawal. I was recently at a psychiatry conference about this. It's coming. I'm not sure we're prepared for it, but there's the questions are now flooding in, Laura. So another GP colleague wanted to know if you have to pay a gap fee and how easy it is to see a GP should you want to see one.
It's easy to see a GP. I have no idea about the gap thing. That I'm gonna have to ask my parents about that one.
And Jason wondering about how you would best access health information. So out with school, where do you find out about health? Is it through web pages, social medias? Does it make a difference if you know the background of the source? Like, are there more people you like to trust? And would you trust an influencer?
I would not trust an influencer. Absolutely, unless they have like I don't know like a doctor degree or something behind them, then maybe. But like no. I always look up stuff. So I find sources that I know are safe, and I'm if I were to guess, I'd say most people with asthma, if they're looking stuff up, they'd go to they just look up their question and click on the first link or second link they find. I think I don't know if people would go out of their way to like follow pages like on social media that have, I guess, asthma information. If they were given that resource, say in like a doctor's appointment, then I reckon they would. But if it just kind of came up on the side, then I don't know if they would.
Do you find any of your friends follow any health advice from influencers?
If in terms of asthma, they wouldn't, but just generally on a general level, yes, there definitely is some things that they'd go, oh, that I'm doing that wrong, or this is unhealthy, or I need to change my ways, or I'm gonna change how I do this because someone that I like said it is healthy. So I definitely the influences do have overall can influence how like you do change.
Yeah. Okay. So do you think, because coming from the dark ages, what we tend to do is say, here's a really good website. But I often think when I open my door, 99 to 100% people are on social media scrolling. And I often think if there was good resources on social media that a GP could pinpoint you to, and it came up in your social media without you even having to look for it, would you think that would be a better way of getting information, or having it more at your fingertips and having to type in a web URL?
Potentially, yeah, for sure. I think it would just have to be a popular name, if that makes sense. So I don't know how, like, if it was some like really dodgy looking kind of thing, I'd just kind of go, I don't know if I want to actually trust the advice on this. But if it had like, I don't know, like say it was, I'm gonna just use Care Health as an example. If it was like a Care Health asthma thing, I'd go, oh, sure thing, I'm gonna trust that. And I could see that they were, say, following Care Health in there, like listings, then I trust it.
Yeah. So if GPs were to advise that, we just need good resources. I don't have Taylor Swift on speed dial, so I probably can't ask her to help. Right, we're blowing up about TikTok as well. That's the really young people's stuff. That's your age. I don't think any of us know what TikTok is really. Maybe you do, but but I think it's like Instagram but dancing and faster. Esther, just agreeing with you. You guys are a huge group that we overlook because you're getting this autonomy. I'm speaking a little bit about it and taking charge of your asthma care. It's really important to hear from you. And Laura, Stephen just wants to know, do you have a good relationship with your GP? Do you feel comfortable asking your GP questions?
The main GP I see, he's really good. So yeah, I definitely trust him for sure.
Thank you so much.
Thank you so much for taking that many questions. And you can see the value that you bring just with the number of questions that's been flooding through. Thank you very much, Laura, for your time and your honesty in sharing with us. So we might hand over, there's claps for you too, Laura, hand over to Anna Marie, who's a mother of a younger child with asthma. Anna Marie, all yours. I'll click onto the next slide.
Hi, everyone. Thanks for having me and the opportunity to share our story. My daughter is 8 years old. She was born premature at 28 weeks, and she was diagnosed with viral-induced asthma back when she was about 2 years old. I just wanted to start off by showing you a couple of pictures, and yes, she's cute, but that's not the only reason. Just to show you some of the journey we've been through, that, yeah, it might look like we're doing all okay, but as I go on, you'll just realize how much stuff feeds into all of this. Just the first one is obviously she wasn't at the GP, wasn't in the hospital, she was at the dentist, but just how important the primary carer is for the child, and how, like, she just hangs on to me and will feed off me wherever we are. Just the GP visit. Yeah, her GP at the time loved her dearly, so took photos of her, but just a picture of, the stuff that we have to bring with us, what we have to think about. And the last one is in emergency at Sunshine Hospital after one of many admissions, with her viral-induced asthma, eventually got diagnosed. She was basically high on, I think it was the Ventolin at this stage, and she was racing around the ED in her little car at that stage. So yes, cute, but terrifying at the same time. So I'll just go on to the challenges. So the first, I just put them into like categories of cost, short-term fixes. We get a one size fits all, which Esther kind of alluded to as well with the asthma plans, support and education. For me, one of the major challenges going through all of this was that the cost of actually having the kits set up, because you need so many. Her father and I, we weren't together, so we needed a kit for him, a kit for home, a kit for daycare, and a kit just to have with us. I wasn't aware that you could get spaces subsidized at that stage, so it could cost upwards of $40 for a kit. Being a single parent on a quite a limited income, it's quite hard to do, and that responsibility falls onto me, which stretches other things as well. Then the one size fits all kind of process that you get put through. We had about I can't remember exactly, but maybe 4 or 5 admissions almost monthly when she was 18 months. And at that stage, the guidelines were you really can't diagnose asthma under 3 years of age. So it was really being stuck in on that. And because of that, we got put through the system quite a lot, and a lot of medication, a lot of time off work, a lot of, trying to navigate life alongside with all the other problems. Education was quite limited. Didn't know what to do, didn't know where to go. I used all the resources I could. My paramedic friend, nurse on call, maternal child health on call, you know, 000, paramedics coming to the house, everything, to try and not go into the hospital system. But because there was the short-term fixes each and every time, you kind of had to go into the hospital system, unfortunately. If you can click, please, clap, Catherine. Thank you. So there, the middle part is kind of like the things that you can see. You know, cost, it's a one-size-fits-all. The support, the education kind of really wasn't given. But then on top of that all, we have, you know, kind of trauma from prematurity and her not being able to breathe, you know, when she first came into the world. So that brings you back into that. At the same time, there was relationship challenges. You had to fight attitudes of others in family and friends about, you know, does she have asthma? Does she not have asthma? You're giving her too much of this. You're being a crazy parent. It should say mental health, not mental health. Sorry about that. You know, if you think about all this stuff going on and you're in the hospital system or you're in the GP, having to be really on point and remembering everything that's been thrown at you is really hard with everything else going on. If you think about hospital admissions, look, you know, sometimes we were there for 3 or 4 days. There's no sleep. So knowing the questions to ask and being really on point, and then taking that home and following the guidelines or whatever was told to you is really tricky. Because of the short-term fixes, I think, Esther, you mentioned that as well. You know, that kind of short-term, the hospitals have got it, it sounds terrible, but they've got it's just the way the system's set up, unfortunately, to get you better and connected back out with your GP. Your career takes a hit. Do I have enough leave? We're in the hospital every month or so. We're going to the GP visits all the time. You can't progress your career because you're not there enough. Then you don't have the leave, and then so you're not getting paid, and then you've got all the, you know, it's a vicious cycle, and then trying to follow everything on top of that. So next slide, please, Catherine. Thank you. So what worked for us, I was really fortunate that when Alice was born, the team at the Royal Women's was so amazing that they empowered me. And every time they did their rounds, they would come and ask me straight away, how is she today, Mum? So understanding that they empowered me, and they made it quite clear that I was the expert on my child. I would see the slight little changes. And because of that, I understood that, you know, I'm her advocate, and I really have to, you know, stand up and ask the right questions and be on point. The preventer medication was a massive turnaround for us, and finally being diagnosed with what was called viral-induced asthma at the start. Having that preventer medication, we didn't have another hospital admission since she was 2, so she's 8 now. So we're managing it. She's really well managed now. Taking notes was a big one. I had to bring a notepad, and you probably do it on your phone these days, but yeah, taking notes on everything, and which actually also helped me clarify what people were telling me. Understanding my child's triggers, and really a big important one, and a lot of I can't think of the word, sorry. The hospital, you know, the system will connect you back with your GP. So a lot gets placed on the GP. But having a trusting relationship with your GP and knowing that you can ask the questions and not get a face that says, what are you talking about? You know, making you feel like you're a little bit hysterical, you're a first-time mum, maybe you're a little bit scared of things, you know, or you're overreacting. It's just huge. I'm fortunate now that I have a GP that I can trust and ask questions to. And I just think, yeah, that's one of the big key things, because they can point you in the right direction and kind of work out what you need. For solutions, sorry if I've gone too long. I went to a Safer Care session the other day, and they were talking about a program. I can't remember who it was through now. Anyway, it's called Teach Back. So it's a little training package that's been put together about language and how you use it to check in with your patients about if they've understood things. I mean, I think from the hospital to the GP, there needs to be that extra running support system, which the CAP program obviously does. I didn't know about it before, so that's awesome. But that really needs to be embedded in all touch points where the patients comes through. I think empowering your patients just with simple language of, showing that you trust what they're saying. Understanding also that we have so much access to information now. So, and yes, it might be annoying, Dr. Google and everything, but we can find a lot of information. So if the patient feels empowered, they can go out and do a lot of that research. So, GPs and the medical professionals don't have to be like the only point of information gathering. They check with you, of course, because they trust you. But yeah, we can bring a lot. And language is huge. I think the way in which we speak with everyone is huge. I've just thrown in also bias, because it's it's something that maybe we as parents, we probably label ourselves, and even medical professionals wouldn't do it, but checking in with your own biases on people. Are they a crazy first-time mum? Are they overreacting? And yeah, just challenging your own biases. I think that would really help. I just found that little unconscious bias toolkit. It's anesthetists, I think, can't say it, but what I found there was pretty cool, pretty easy to follow, I thought. But yeah.
Thank you so much again, Anna Marie. As always, we can always rely on you to be brilliantly honest and talk about the things we need to talk about. I loved all your slides, but I especially loved that last slide. Unconscious bias in patients and also in doctors. Communication and language, the words we use, so important. And checking understanding. These are like the pillars of GP education. But as I was going to say, we don't always do it, and the reasons why. But thank you so much for bringing them up, because unless we have people holding us accountable and saying, actually, they do matter, you do need to do that. We're so science and clinical and cleverness orientated. Oh, look at all the clever things I know. That sometimes we can forget that that's useless if you don't communicate it in words even a 5-year-old can understand. Because what's the point in having any form of knowledge or a degree if you can't actually use it to empower patients? So thank you, that was really brilliant. Everybody just echoing that in the notes, and we'll try and get those resources that you've put there, because I think they're brilliant, attached to our notes for this evening. Anybody got any other specific questions for Anna Marie? It's gold dust getting patient of a young child with asthma here to ask. One other thing I really loved you saying was that you were empowered to be an advocate. I'm saying to everybody at the moment, because our healthcare system's breaking, if not broken, and I'm saying you have to advocate for yourself, not just as a parent, but as a patient. You have to make sure you're getting the care that you need. You have to make sure you understand, and I think that's brilliant. And something I always like to check that I don't think there's such a thing as a crazy first-time mum. There's just a first-time mum, I was crazy too. I think you can just take the crazy out. You're responsible for a tiny human being or 2 or 3, and a premature one? Come on. And often when people come to me like, oh, I think I'm being a hypochondriac or I'm being crazy, as opposed to being like, no, or dismissive, I'm like, yeah, because that's normal. You're acting like a normal human being. I can't imagine having a premature child go through that and trusting a bunch of strangers to do the right thing by them when you're the only thing that's kept them alive for the previous months, and not having a level of hyper awareness, hyper vigilance, even the PTSD of hearing the beeps, the signals. I have a lot of patients who have been in that situation and they find it really hard going back for the outpatient appointments, things that they didn't realize because it was just their norm for months. So I think, yeah, you don't need to put the crazy there. You're just a first-time mom going through it, and everything you did and everything you felt was totally normal. And again, something for GPs to pick up on if we do feel that that's turned into anxiety, and to support the parents through. But yeah, all questions in new time parents are completely appropriate because you've never done it before. Again, it would be a bit like doing a degree and expecting people to know it on the first day. You don't. You've got to ask and you've got to advocate, because if you don't know the answer, you don't know the answer. Simple as that.
Yeah, this was it also, I just add in, like, no one in my family had asthma.
Yeah.
No one in her dad's family has asthma. So it was the first time for all of us.
Yep. And we've been doing this for 2 years. It's clearly not a piece of cake for us. So expecting people to understand it first time off. Thank you so much. I think probably in the interest of time as well, I might have to gibber on again. But you can hear me chat every couple of months, so it's probably less important. Any other questions for Anna-Marie? I think Catherine will be monitoring the chat through there.
But I think in the interest of time, we might move on to you. It's your next part about the GP's perspective. And we want to leave enough time for Joanne too at the end.
I'm going to whip through. So I'll give you some points and then I'll summarise with what I think the issues are. GP is huge and complex, and we don't work in a uniform organisation. So it's hard. Things I'm focusing on are, I take it for granted that I come from a hospital background. So I was doing geriatric training before I switched to general practice. I also come from a long family of general practitioners and nurses. So GP's in my blood. I've always known the way GP works. And I still forget every day that a lot of people don't understand GP clinics. They don't understand how they work. They don't understand appointment time and schedules. So I'll go through that a bit as well. But I thought I'd start with patient-centred because it's all about the patients. So we talked a bit on language barrier. I think somebody had said, I think Esther, you'd asked how much we hand them out. Most of my patients have English as a second language. So yeah, that's a resource. The National Asthma Council and Asthma Australia all have translated resources. And I, in the interest of time and patient preference, I use Google Translate a lot. Trying to find the extra time to have a translator and do that practically when the patient has turned up and you weren't necessarily prepared for it is hard. So often I will use Google Translate if there's salient points that I feel that terminology isn't getting through, and then I'll just follow up with a formal translator. And like we talked before, communication is the bread and butter of GP training, and the hours and hours of constant communication and soft skills training that we do. Very little is on clinical. You learn the clinical of GP on the job. It's all about the soft skills and communication, to the point at some points we thought, are we actually learning any clinical medicine in GP? But validated, because I use those soft skills far more than my clinical skills. And I use my clinical skills a lot. But like we've just been discussing, if we don't have the time and make sure we have that space to ensure understanding. So in GP school, we have a 10-minute module that we're examined on, and we do 5 minutes, cross the bridge, 5 minutes. So the first 5 minutes is the impossible task of taking a history, examining the patient and formulating a diagnosis. Then you cross the bridge to explaining the diagnosis, the investigations, and the management. So go, you've got 5 minutes for each. But that is a model that we are assessed and based on 10-minute consultations. And in reality, I think the average GP consult is about 12.5 to 15 minutes. That's about what I've got for my patients. But a lot of the time, there's things that we do, and the management is sandwiched in the last sort of 2 minutes. And as I think Laura has put up brilliantly, is the transition in communication from caregiver-centered care to patient-centered care. Anna Marie will go through that in a few years' time, where she'll have to step back a little bit and be the supervisor, as her daughter should be asked the questions by the GP. Hopefully she'll have a continuity with her GP. But that's something that we often forget, and I think Laura's spoken to really well, is by the time a child's sort of 10 to 12, often we're talking over them. And by that time, really, they're smart. 10 to 12-year-olds know so much. They can certainly use an inhaler by themselves. On that, a very quick point clinically that I was going to sandwich in there, Laura talked about spacers in high school. Just remembering the new GINA guidelines that are saying even mild asthmatics should be on Symbicort, and the use of a turbohaler instead of spacer can solve that. So education, we've talked about resource provision a lot, and really finding those good resources. That's what I was asking about Instagram so much. Nobody looks at websites these days. And then the baseline health education expectations. I work with a massively varied demographic. I see patients from, honestly, I feel like every country in the world. And there's huge differences in health education expectations. And that's not necessarily always people having a low health education. That is just cultural things, societal things, family things that you're told. I'll often give education to a patient. They'll be really on board, then they'll go back home. A family member will visit from abroad, or they will FaceTime and they'll question it. I would never put myself in the position of feeling that a patient would trust me more than someone who's influenced their entire life. That is a balance that we have to be aware of, because people almost always don't tell me that. I have to ask them, what's going on here? Why, challenging these beliefs, like Esther was talking about the steroids. Different healthcare practices happen in different countries. So a really easy analogy is I get a lot of people from overseas coming in with children with diarrhea asking for antibiotics. And it's really easy as a clinician to be like, oh, why does somebody always want antibiotics? It's easy for us, and I'll talk about the doctor-centered things, to get frustrated with people. We're human. When we get asked questions, we're like, oh, it's viral. Why don't you know this? Because we're not a doctor. But also, a lot of people come from countries where bacterial gastroenteritis is a thing, and that is the norm in their healthcare education. Is young children often go to hospital and receive antibiotics for diarrhea. So it's just sort of understanding that when you're speaking to a patient, when they come in with something that sounds frustrating, and I'm using particularly inflammatory words here because the whole idea for the session came from me thinking we often don't go there. We often don't say things like, oh, I was frustrated. Or we do, and then we leave it. We don't work through that. We leave it as frustration. We don't move on and get to the other side of it. So in my old age and experience, I tried to approach it with curiosity. Someone comes in and says, I don't want to vaccinate my kids. I'm not like, oh, why not? What, you're going to kill them? I mean, that's a terrible way to approach an issue. I'm like, oh, right, okay, tell me about that. It's really interesting. Like, where did you come from with that? And they almost always have a really good reason why. It's not a clinical reason. I don't agree with it, but very few come with conspiracy theories. A lot of them, some just don't believe in vaccinations as well. So you got to really ask the questions, and you're never going to get a discussion or communication really working, or education with someone who you are showing frustration or health superiority to, saying, well, I'm the doctor, I know best. It's not going to work. It's pointless, and it makes you very frustrated. And then I think Anna Marie's talked a lot about trust, the doctor-patient relationship. That's what we're there to give. I went into this with the real birth of death experience. I want longevity of patients. I want them to come back to me. We have a brilliant sort of working relationship within our practice as well. We work really well together. I think our patients trust all of us for whatever they're coming to see, and we all have different specialist areas. So I'm happy to refer to a colleague who's better at surgical stuff. And then the pressure to help, I think, is a big one. Healthcare has a bit of a God complex. it is in us because sometimes we are in life death situations, and I'm not saying we all walk around with big egos, but it's the pressure to be told to help. We are from a very young age, I went to med school at 17, told that it is our job to fix people. And you develop this relationship of service provision and duty, otherwise you wouldn't be able to do the job. And ultimately you want to help people. I want to help my patients. So when someone comes in, we've talked about asthma care plans, and it's the end of a consult, they're like, oh, Krista, can you just, can you sign their asthma plan? God, I want to do that. God, I want to help them. I want their kid to go to the school next day. And we've talked a lot about issues in my area as well, about children being refused camp or school or daycare if they don't have the asthma care plan. I don't want that to happen for any kid. It's just a signature on a piece of paper. I know their asthma is pretty well managed. But that's not the point. The asthma care plan is not a piece of paper. And Laura put that really brilliantly, saying, why was I getting this every year? Well, it sounds like maybe the asthma wasn't being reviewed every year. It might have been well controlled, but it shouldn't have just been a piece of paper. It should have been a real review. So now, even though I want to help, I do those difficult conversations of nope, I'll give you my generic letter. I have a generic letter that I give to schools saying they can attend school. It's not the law. The law is actually they should be attending school. Their last year's asthma plan is still valid. They still have a Ventolin, they still have asthma. They can wait a few days, they can wait a week, they can wait 2 weeks until we can schedule an asthma review, because the more I perpetuate doing pieces of paper for pieces of paper, I find that frustrating and it's bad care. So I'm then not going to be the best doctor I can be. But also Anna-Marie has talked about her experience as well. We offload that the asthma review has been done when it's not been done. It's not been done. And if you don't share the education, if you don't show, I thought Catherine's slide was brilliant about the things that hadn't worked. The really small things, just, I mean, nobody had a spacer looked at. If you don't know how to use a spacer, then you're not going to get your medication into you. It's so simple, but you have to do it. So I think that's probably the patient-centered things. And then doctor-centered, so just to run very quickly through time. God, we all moan about time, don't we? But it's hard. So just to run through, just for those who might not be au fait with exactly how GP works, I see about 30 to 36 patients a day, and they are scheduled for 10-minute consults, but I have a break every 4, so it works about 12 to 15 minutes per patient. I have 40 minutes for lunch, which never happens. That's my paperwork time, my calling people time. And the funding for that is variable, depending. We're predominantly bulk billing. We have mixed billing for certain patients. But the main thing in general practice is it's like a mini ED. You don't know the acuity. So I don't know if someone's coming in with asthma for an asthma review or they're acutely having an asthma attack. I don't know if someone's coming in with chest pain and it's some costochondritis or they're having an MI. I had a sequence of Friday afternoons where my last patient different patients kept on having strokes in the middle of my consult. I think the paramedics thought I was some sort of cursed person, but you just in GP we have to get through workload, and it's, I think a lot of people think, oh, it's to make money. That's not what the funding is. We had a rough estimate of if I saw less people, if I saw 20 people, I'd love to just see 20 people a day and give them all long appointments. We took the 6 practices in the block around us near Werribee Mercy Hospital and looked at the impact on patient consults that would cause. Something like 2 million patients a year who'd be turning up at ED and outdoor services. So GPs are trained to do 10-minute consults. That is the model of care, is sharp chipping away at things continuously. But when you, as Anna-Marie has said, are a busy parent and your GP says, no, I can't, can you come back tomorrow? Can you come back next week? No, I've got a life, I've got stuff on. If that involves a fee, that's even harder. You know, you really need the GP to say, I won't charge you, I'll bulk bill you. And then it comes into the funding model. We bulk bill kids, but when we talk about funding, GP is under huge strain at the moment because we can't afford mortgages. As in not our mortgages, mortgage on the building, mortgage on the business, the power rates, the rent rates, the staff rates, and the bulk billing model just doesn't work. So you have to choose these things when you're managing a business as well. It's really difficult. And then education for GPs, we're really well educated, and often that's sort of forgotten. And it's keeping up to date, but you need a background. So my background is hospital medicine. So I did hospital medicine, I did aged care, I then had a year doing expedition medicine, I then did my GP training. I was astounded when I went to GP training that peds wasn't mandatory. And I made sure I did my 3-month peds, because the last pediatrics I'd done was in 4th year medical school. I had no idea what to do with a child. I was pretty much a geriatrician. So a lot of my colleagues went through general practice without ever doing pediatrics. And I did pediatrics, and it scared me so much. I did my diploma of child health, which is the first part of the Royal College examinations and the GP specific clinical. And then I now work in an area where predominantly what I see is peds. I've done co-consulting with the RCH for pediatricians for a year, and I do this. So I've worked hard, because my demographic is peds, to do a lot of peds. But you go to an older demographic. I was speaking to a friend at the weekend who mostly sees older Caucasian patients over 60. His pediatric asthma is not going to be on top of it, because it's not what he's doing every day, and that's just the way it is. Keeping up to date is there's loads of resources. That's not an issue. It's knowing what to come across, and cohesion. So it's making sure we're all learning the same things from the same people, because Esther said, if you're just going on what a private, no disrespect, private, but one private pediatrician in your local area, so you're rurally, is doing, that's often where we learn, oh, the private pediatrician who my patients see always does this. But that's just one point of view, and it's not that they're wrong, but there's lots of points of views. And if you're just learning that way by experience or what your locality does, it's really hard. And then the last thing is autonomy. So this is like the opposite of hospital, and what I love about general practice is autonomy, control. I work one-on-one with my patients, and it's never textbook. None of them fit into textbook, especially the preschoolers coming with their coughs and their colds. And the beauty of it, and why I love it, is because you can bring it back to first principles. I'd say general practice has been using steroid inhalers post-virally for cough that's probably been asthma, but we were never told it was asthma, for quite a long time, actually. We use them a lot post-virally in adults as well. You know, COVID is a perfect example that shows that now Symbicort is used for cough and COVID because of the inflammation. Well, you know, pneumonia does that, and influenza also does that, and RSV does that. So we do use a lot of steroid inhalers in general practice. And it's not guidelines. And I'm not advocating letting loose and doing whatever you want, but when you bring it back to first principles and you see what happens, same with antibiotic use. I'm from the UK, never prescribe antibiotics, but sometimes you do see someone with 4 weeks of cough and you just get this clinical feeling, and you're like, you've just got a little bit of a bacterial infection, maybe 5 days of amoxicillin. Sure enough, they get better, and you're like, oh well, there you go. So that's it. And then just I'll let Joanne get on because I'm running into her time. But just a reminder to all the healthcare professionals and the year 12 student here, and Anna Maria as a parent, burnout. That's often why we're not doing what we're doing, is because we've burnt out and we're not looking after yourselves. So look after yourselves, everybody.
Thanks, Kirsty. For the interest of time, we might just have questions for you in the chat, if that's okay. I have the pleasure of introducing, I think Joanna has piped up in the beginning and sharing her expertise with us. Joanna is a nurse practitioner that used to work at the Children's Hospital and has joined a community asthma program in co-health. And she has a vast experience in this area. So in the interest of time, I'm just going to hand over to you, Jo.
Beautiful. Thanks, Catherine. Thank you so much for having me to speak tonight. And I feel very privileged to have been given an opportunity to run what is a pilot program within the community asthma program. So hopefully lots of people are already familiar with the community asthma program. But if you haven't heard of it before, I was very fortunate to join the team early last year, and having come from ED, I would like to just say all the speakers that have come before me have really reassured me that perhaps we might be heading in the right direction with this pilot. And certainly Esther's presentation rang really true to my ED experience. And then Laura, with all of your kind of adolescent experience, also rings true to what I'm seeing in my practice around teenagers, which I'll talk a little bit about in one of the case studies, but also my teenage daughter would also echo lots of things that you've talked about today. And then also for Anne-Marie with the parent experience, I'm also seeing that echoed in a lot of families that I'm talking to. So I do feel reassured that perhaps we're on the right track. Certainly, this doesn't provide the solution for all of the things we've talked about. It's just kind of scratching the surface, but hopefully you'll come along with me for this journey. So Community Asthma Program has 2 arms. I sit within co-health. There is also the DPV arm, and I'm sure some of the girls are on here tonight. With this pilot, I would maybe hope that in the future, perhaps that the service we offer for co-health could also be replicated for DPV. So the poster there is our poster that people will see up. People can self-refer. They are often referred from tertiary hospitals such as the Children's, Werribee Mercy and Sunshine to our service, and also obviously the Northern for DPV arm. And families can also self-refer. If you'd like to next.
Yeah. Oh, I couldn't wait till now. I'm exhausted.
Oops, Lou was just on saying hello there. If we could go to the next slide, Catherine. So I'm hoping to very quickly go through what the service is, give you an outline. I won't dwell too much on this particular slide because these are the things that we'll touch on as we go through. So the only thing I'd like to sort of add to this little kind of rundown of what we'll go through tonight is that we do have great access to interpreter services. And I know this is a challenge for general practice. And because of the model that I'll discuss, I have a little bit more time and a little bit more planning because I'm often not seeing children who are acutely unwell. So my model fits really nicely with being able to use interpreter services as well. You can go to the next slide. Beautiful. So the actual work, the way that we've set up the program, this is kind of the nuts and bolts of it. And I would have to say that, and I sort of just thought of this as we went through tonight, that people who come to the CAP program, it gives us an opportunity to have a space where families are already engaged to a degree. So then for me to come in a clinical capacity, families are fairly open, and this might be a barrier in other services, but it's certainly something that may be unique because I sit within CAP. So I think keep that in mind as we go through. So we offer families who are engaged with the Community Asthma Program who fit certain criteria, appointments within my clinic, which runs 2 days a week, currently at Braybrook and North Melbourne. We initially started at Collingwood, but found that it wasn't probably as family friendly as our North Melbourne site, which is working very well as it sits within a paediatric allied health cohort at North Melbourne. But remembering a lot of our clients are in the Western corridor. So really, so far, a lot of patients are probably still preferring Braybrook as the site to North Melbourne. But as this is a pilot, we're trying to be a bit flexible and make changes as we go along. So I offered them a 45-minute to an hour initial consult. This is a really long consult. But when we looked at this model, we felt that this is what families needed. And to date, I use every minute of that 1 hour. And some of the case studies will show you a little bit about why. And then we offer 30-minute review appointments. And for most of the demographic, that might only be 1 review. But probably the most common is at least 2 reviews. And then for other families, I've had multiple reviews with them to get them on track. Obviously, I'm very, very fortunate to sit within the Community Asthma Program. So every family has educator support and collaboration. And sometimes that is actually the educator sitting in on my consults as well, so that we can then be on exactly the same page. Something that was mentioned, I think, by Laura was that families don't always have access, actually in Anne-Marie as well, the cost of resources. Again, currently with our program, we do have amount of funding that enables us to provide spaces, additional spaces for families who are finding that a challenge, and masks. And because I also address comorbidities in my clinic, so allergic rhinitis, eczema, we talk about allergies, and there is also referrals involved, which I'll get to. I also have eczema products that I can provide families with, either to trial, or if they're really finding it challenging with the cost, sometimes I can give them some larger samples as well. So it is a bulk bill clinic, if I didn't mention that before, which is wonderful for families and access, possibly not so wonderful for the ongoing service. So we'll see how we go with funding for the future. But yes, that was the design we wanted, because it was all about access for families. I'm going to pop to the next slide, please. Perfect. So when we came up with the pilot, we had a look at what our aims were. And these we arrived at these really from what the current experience was of the educators, having worked with families, and also some of the outcomes from the ICAM project, which probably Catherine can talk to as well. But our main aim was to improve access for families of children with asthma in the post-hospital phase, but also for ongoing asthma assessment and management. And we wanted to ensure that all children who are engaged with the community asthma program have a written asthma action plan that's current and up to date, which also, as Kirsty mentioned, involves actually having an assessment and review. But that point was put there because we know that the research tells us that children with asthma action plans are less likely to end up back in hospital. So that's why it's in that dot point, but it does sit within an asthma review. That they had current prescriptions for preventer medication if a preventer was indicated. So we've found that another barrier for families to adhere to their management was perhaps running out of their preventer medication, not able to access their GP, or have a financial barrier to access their GP to then continue that medication. And also that from the educator's perspective, some of the management that children were having didn't necessarily align with current best practice. And I think this probably just lends itself to the point that Kirsty made, is that not everyone is up to date with what is current best practice, and that the pressures, particularly in community health, so for general practice and other people who work in general health, is that, yeah, you're so stretched with your time, and that it's not always easy to stay up to date with best practice. So that was part of our goals or aims, and that we really wanted to build GP connections and act as a bit of a liaison and a link for families with general practice, because the educators noticed that a lot of families would come through and didn't have a regular GP if they used one at all. Often they would use the emergency departments as a surrogate for having a GP service, or they had not a regular GP, so they would see lots of different GPs and not necessarily even be committed to one practice. So part of our goals were reconnecting people with their GPs and trying to build a relationship and a link. And I'll talk a little bit about how I do that, hopefully. And then obviously knowing that managing all of the comorbidities that children have in conjunction with their asthma improves their asthma outcomes. So we look at all of those things within the clinic appointments. So all of our families, we either ensure that they have a GP, find the GP details, and they all have a letter written after their appointment to update that practitioner on what has occurred during our appointment. And if they don't have one, we try and make recommendations. And as soon as they've chosen someone, I then will send a GP letter at that point in time as well. And in the interim, I will have ongoing reviews with that family. We can go to the next slide, please. So this is just a little bit of a visual timeline of how care happens within the community asthma program. So people will come to us via referral. That could be, again, a self-referral, a community referral, or a hospital referral. They have an initial assessment, ideally with their educator first. Sometimes if we're trying to bridge the gap between a hospital presentation and a review after that admission to hospital, presentation to hospital, because they haven't been able to have that with their general practitioner, this might be reversed. So they may come to me first, but the model does seem to work best, just anecdotally, if they've been seen by the educator first, because it means that they seem to then continue with the full program and stay engaged with the educator, rather than getting what they perceive they might need just from me and then not engage with the rest of the program. And we know that the program works best if they get all of the parts of it. So they can be referred to me at any stage in their journey through CAP. So it may be that the educator initially doesn't think that they need to have a referral to me. Perhaps it was a first presentation Ventolin responsive episode that we're now calling preschool asthma, and they hadn't had anything else previously. They've given them education, and then perhaps they've started to notice that the child's having some interval symptoms, and perhaps they've had another episode, and so then they might be referred to me at that point. So they could come to me at any time in their journey. And then we have the 1 hour, 45-minute assessment, in which I look at all aspects of their health and their asthma history and their general history. And then we potentially may hand them back to their GP at that point, or they may have some reviews depending on what's happened within that appointment. Most families stay with us between 3 months and all the way up to a year sometimes, but generally most families are with us for around 3 months. We can pop to the next slide, I think. So when I thought I would talk through some cases, it's probably less about the clinical management that's happened in these cases and more about giving you an example of the different ways that our clinic can help families. And also a little bit of some surprising things that I've discovered on my journey. So I think initially when we thought about this as a pilot, we were thinking about all the task sort of based things and the gaps we could fill. And I guess we were really thinking a little bit about ourselves as a service. Yes, we wanted to make these things better for families, but we wanted to improve efficiency and access and all of these things. But some of the things I've discovered on my journey are much more fulfilling and have highlighted to me some things that perhaps I hadn't thought about before, especially being predominantly an emergency clinician. So this first case was a beautiful 8-year-old girl who had previously been on some Flixtide Junior, but had really poor compliance. And just to kind of set the scene, she was one of 9 children. So this was a family of 11. And as is really common with our CAP clients, often they end up with us because they've had an event that's landed them in hospital, or they've been quite unwell and presented to their GP many times. So there's a big disruption to family. So they come to us because they've had a big disruption to how their family is functioning. And so they really want some help to fix that, to stop the disruption. And so we changed her over to Alvesco to help with her compliance. And she had a really great response, and Mum was really happy with how she was going, which actually led her to bring 6 more of those 9 children to the clinic to have some care with us. And I think the things that led her there were that some of the barriers had been removed for her to get some help for those children, which was we were able to offer, back-to-back appointments for her children. We could offer the education around the same time, so she wasn't having to do multiple appointments. They were also bulk billed appointments, so you can imagine the cost for this family is significant. And also time disruption, we could minimize it by clustering everything together. And I guess the biggest point I wanted to make from here that I was learning is that often families are focused on the sickest child, and that's the child that they present with, and that's the child they bring for help. And there's also maybe a level of acceptance that children with asthma get sick often, or children with severe asthma get sick often, and they kind of accept that that is the lifestyle. And for this family, they had recognized that the sickest child is now very well. Perhaps the other children could also be very well, and the disruption to our family could be very limited. And I think that's what we achieved with this family in the end. So there was a lot of compliance challenges, including the fact that we had some adolescent boys in this family who were not taking their medication because it wasn't cool. They didn't want to take spaces, and we were able to switch one over to smart therapy, and also meant that they were performing better in their sport, which was very important to them, so soccer in this family. And also we addressed for these children, because most of them came with an additional issue of either allergic rhinitis or eczema. So if I had free access to nasal corticosteroids, I think that would be the next best thing in terms of cost reduction for people, but we don't have that at the moment. So for this family, it was then developing some charts so the kids could keep themselves accountable for their medications and keep each other accountable. So the ones on Symbicort and Flixitide knew that they both were twice a day, and they needed to keep the big kids accountable, and the little kids took on that role. And then there was a different picture for the ones who were on the Albesco. So we created a plan that was tailored to this family, and I think we have highlighted how important individual care is, not the one size fits all. And so when I say I want it all, I want all of the kids with varying levels of asthma to have the best care possible. And so I think that's my message for case 1. If you'd like to move to case 2, please tell me if I'm going too fast or I'm talking too much, because I could talk forever about this topic. So for case 2, this one is really highlighting how unique it is to sit within an education service. And so the fact that there is some team members that are delivering care, also making their own assessments, and that we can team up, and that we're seeing these families over a time continuum, means that we get to figure some things out that would be very challenging in other settings. So this is another actual, she was 8 years of age. They were actually a self-referral because they lived out Winchell Seaway. So they were out of catchment, but Mum was quite desperate because there wasn't a lot of infrastructure around where they lived in terms of access to medical care. And she'd even been using the Northern Virtual ED. So this young lady was having quite regular flare-ups, didn't currently have a GP, had previously had one when they lived a little bit closer in to Melbourne. And we said we would take her on even though they were out of catchment, and initially offered a telehealth appointment. And within that appointment, we discovered that at 8 years of age, she actually had been started on a Symbicort Turbohaler at age 6, which she wasn't able to coordinate. And if you are across, which I'm sure most of you are, the current guidelines, this would not be indicated for a 6-year-old. Currently it's for 12 and overs. So we recognise that she was probably on the wrong medication and possibly not even getting the medication properly because of the device and technique. So we switched her across to Alvesco and looked at her in spacer technique, so reintroduced her to a spacer. She also had symptoms of allergic rhinitis, which we started treatment of, and everything was going okay, but she was still having flare-ups. And because we were working as a team, both the educator and I made the connection that they were happening on a Sunday. But the family were like, so what's happening on a Sunday? And they were like, nothing. There's nothing that's happening on a Sunday. She doesn't do sport. She's just at home. And so the family were getting quite desperate and decided to come in for an in-person consult. And during that consult, we were able to pin down, because we were now face-to-face, and Mum presented with Grandma, she was comfortable disclosing that she vapes inside on a Sunday and that her partner is also vaping and that they were both vaping inside. And once we could identify that trigger and explain that this was probably the detrimental trigger for this person, and they corrected that, moved it to outside, she's stopped having flare-ups entirely. So having the timeline, the multiple team members, building a rapport, and then being able to then have the family be comfortable to disclose something that she was feeling embarrassed about, enabled us to kind of nail down what was going on for that patient. Beautiful, we can move on. The last one, and again, because this is a pilot, we've been able to try a few different things. When I first put the, I guess, the financials together, we didn't think that it could work to do home visits. The CAP service has always offered home visits as part of education, but we couldn't really see how it might work for a clinic based around time and getting numbers of patients through. But what we're thinking at the moment, and we thought it was worth a try, that for particularly vulnerable groups, perhaps we could offer this as a very limited part of the service. And so this family, this boy was around 7 years of age, attending primary school. There was a really complex social history. Parent had passed away maybe just a year before. He was of Indigenous background, and there was a lot of health anxiety, not just around his own asthma, but also the fact that a parent had been through the health system and then passed away, so it was quite complicated. And so the idea of that child coming into a health service was very challenging and confronting. So we were able to offer a home visit, and the educator and myself both went. So we could do assessment, engagement, and education all in the one package. And, you know, in terms of mental health support, they had tried to access traditional psychology previously, and he wouldn't engage. And I guess we were able to spend a little bit of time, and we were able to do his assessment, provide the education. He was comfortable and happy in his home. And we talked a little bit about alternatives for mental health support that he might be interested in. So this is a boy who likes his iPad, would be happy to use like some self-directed CBT. And so he we recommended the BRAVE program for him, which some people might be familiar with, just to reintroduce him to some of the things that might be helpful for him. And that family's continued to engage with the service. He didn't have terrible asthma, but this was an opportunity for us to build a relationship with a family who are now continuing to engage with the service. And I think that that's worth a mention, just in terms of how this service could work for particularly vulnerable groups that might not be able to access traditional services. So that was case 3. You want to pop across. So our current patient demographic that's coming through the clinic, I would still say whilst we see age 1 to 17, I predominantly am seeing younger children, and that is a reflection of the community asthma program. We predominantly see younger children. I have still had some adolescents, but I would be really interested to see that more of the adolescent perspective on how they would like to access health services, because I think we are missing that in a big way. A lot of them will come with a GP or without a GP, and my hope is, and I haven't had much feedback from GPs to know yet, but my hope is that they're finding my communication that I send out to them helpful, useful, that, yep, Kirsty says thumbs up, that they're coming a little bit more packaged so that from a time point of view, the GP doesn't have to do all of the deep diving and the hard background work, that they can then continue on with what's been started, and that hopefully the information we're giving families makes them feel empowered to reconnect with their GP, and that we're really spruiking the value of having that ongoing connection with their general practitioner, that it's really important for those 3-month, 6-month asthma check-ins, even if you're well. So we plan for that when they're discharged from our service, that is their next plan. So their next plan is you need to see your GP in a month, or you need to see your GP in 3 months. And I would communicate that with the GP as well. Lots of our children are coming with undiagnosed allergic rhinitis, some eczema thrown in there as well. Lots of our kids have allergy and anaphylaxis, and probably some of the things that we're finding is perhaps they haven't been on the right preventer to support their anaphylaxis diagnosis, or perhaps they haven't been on one at all yet, and then have made some referral to specialists, and that might be around ear, nose and throat, or allergy, or general paediatrician. Occasionally so far I've come across some developmental concern, or obviously mental health concerns, and we refer out to the appropriate person. We can go to the next slide. So I know we've been talking a little bit about gaps and barriers, and so I thought I would have a little look at, what are some of the barriers for families being compliant with care, education, treatment plans, and how we're trying to address that in this clinic. So access is something that's already been spoken about quite a bit tonight, but the fact that we're a bulk billing service, that currently I have some availability, so we can be a little bit flexible with families, that we offer a telehealth arm to it. And obviously I have the luxury of having a background based at the Children's Hospital and lots of amazing people that I can phone as a phone a friend. So having connections that sit within those specialties is, I'm very privileged to have those. So I've been able to access best practice. We are able to address medication compliance because I sit within a team of educators as well. And so we look at what is the barrier for this family and trying to address them and then support them so that they can be compliant with their medication. And we provide lots of resources, which again, hopefully reduces barriers for these families. And then if I'm looking at healthcare professionals, so I guess we're mostly talking about general practice because that's where I'm then sending them to most of the time, although sometimes it is back to the hospital. Just trying to to reduce some of those barriers by offering up support and collaboration to the general practitioners by way of, you know, how we interact with the clients and in the clinic level, but then communicating with those general practitioners. And then again, promoting the benefits to families of having these strong relationships, and then obviously being able to send out the information to general practice about what are the current guidelines, just so that it's hopefully easier and quicker to find that information. They don't have to go looking for it, and they can link it directly to the patient in front of them. That's my hope anyway. Beautiful. Next slide. So this is a pilot program and we are evaluating it as we go along. There has been a few barriers to our QR survey, but we are collecting REDCap data. There will be interviews, and we have already had some lovely feedback, and some of my CAP colleagues might be happy to talk to some of that just through our normal feedback channels as well. I just popped a little link in the bottom there, just if people would like to know a little bit more about nurse practitioners. I know I didn't have much time to actually explain what a nurse practitioner is, and for some people that will still be a fairly foreign term. So please feel free to reach out if you have any other questions about that. And also just, I think it's important for me to share for the general practitioners that CoHealth has also is supporting me in so many different ways, but I have once a month clinical supervision with one of the GPs from CoHealth. So that enables me to run lots of things past him and get a GP perspective as well. So I thought that was probably worth sharing as well. We can flip to the next slide. Some information about how to refer to the service. So you can't refer directly to me. It always comes through CAP. So you refer to the CAP service. And again, the NP clinic currently only sits within CoHealth, but obviously DPV offer an amazing service as well in the form of support and education in the Northern Corridor as well. And I think that takes us to the very last slide, which is to thank you all for listening to me waffle on about my favourite topic of the moment. And yeah, thank you for letting me share my journey so far. Hit me with the questions.
Fantastic, Jo. Thank you so much. Your service and the whole community asthma programme service is phenomenal. If you haven't referred, I highly recommend it. I keep saying it, but it is the most useful clinical service that I've contacted in. I'll let Catherine have a look at the questions if anything comes up, but we are over time, which is always a good thing, and nobody's logged off. So thank you all for staying. This is our little mention about health pathways. If you're looking for resources as a professional on what up-to-date guidelines are, there's always the RCH portal, but we formerly used health pathways. You can get a username and log on from your practice manager if you don't have one, and you go to pediatrics, respiratory, child asthma. It's got acute management for acute asthma. It's got chronic management per age group, and it's got all the resources you would need. It's a really good resource. And then just to wrap up, thank you everybody. Thank you all the presenters. You were all fantastic. Great session as usual. And I don't know the stats, but it looks like it may be one of the best attended sessions. There seems to be loads of us. Your feedback was brilliant. So if we could do the survey, I know you've been here really long. If you use that as a QR code, we really appreciate that. This is a project and we need the feedback to see how to improve. Let me know if there's any issues with the QR code. It's also been popped up there, the link to SurveyMonkey. If we flip past the QR code, you can get the link in the SurveyMonkey there and do it just now. The next community of practice will be Wednesday, May 22nd. I think that will be our second last one. Am I right, Catherine? We don't have a topic yet. Feel Feel free to let us know if you think anything needs to be covered. I've got a couple of ideas that are probably more community orientated. There is talk of doing an education day instead of a final community of practice, which would be July or June. I think we have to squeeze it in at some point, June or July. So we might do a face-to-face or online education day summarising everything we've learned from the last 2 years, which I think would be brilliant. But meanwhile, if you'd like to suggest topics, things you want covered for the next one, please feel free to contact us and let us know. Otherwise, I think that's it. Thank you everyone for coming, spending your spare time learning about asthma and hearing these incredible stories, especially thanks to our consumers. Your time is so valuable to us. I think that's it. Good night.
Thanks, everyone. Good night.